Rosie Gonca Gulsen, welcome to the show. So we're so glad to have you on board and talking about borderline personality disorder from a counseling psychologist perspective. Thanks so much for doing this.
Thank you so much for having me here. I'm really happy to be here. Thank you.
Yeah, I mean the pleasure is always ours. I mean meeting amazing people like yourself, and you said out of the UK in Yorkshire?
Yeah, I am studying in Yorkshire at the moment, and I'm also doing a doctorate and also doing practices and like placement. So yeah, I'm in the UK right now.
Okay, that sounds like quite a busy life actually, with lots of things going on.
Yeah, it's sometimes really hard to find time,
Yeah.
but nice to do something which is helpful to people and myself, like
Mm.
most of it, I think.
Yeah, so I mean, it makes me appreciate even more, your time, doing this with us. So I think let's go into it. I mean, so I think obviously we have an outline, but we want to go through the topic of personal or borderline personality disorder. So in your words, Rosie, would you be able to tell us what that is?
Yeah, borderline personality disorder is usually emotional, unstable personality disorder. So it actually starts off in like earlier ages and it's gets better with age, like the research shows. But it's like they experience a lack of sense of themselves and they experience strong emotions compared to other people, and they tend to feel very empty and some of them do self-harming, not necessarily all of them, but like they are really afraid of abandonment, the people who suffer from borderline personality disorder. So for example, if they're in a relationship, even like a smallest thing, like if somebody wanted to go to some other city, they might feel abandoned and then they might act very impulsively. So I think it's more about impulse and instability. And lack of self. Um,
Okay.
and sometimes it might cause the detachment from reality, even because I think it's like it shifts the perception of people who suffer from it.
Okay. And would you say it's like, I mean, is someone like that a lot more clingy? I know you said attachment. Is that another word that normally comes to mind?
Yeah, I think based on the theory, they tend to have like usually they tend to have a fearful avoidant attachment style. So it's like they want to get attached, but they're so scared of abandonment that it's also related to the object theory, like in early ages. So once the baby sees an object, usually they connect to the object, whereas with borderline personality disorder, they don't feel very comfortable with their, like they don't really have that normal bond with their parents. So once they're out of the room or once an object is out of sight, like an object permanency, you feel like it's already gone, whereas it actually is still there. So with borderline personality disorder, it's like they really afraid from being attachment, but they also want to be attached. So once they're attached, it actually causes the inner conflict, and that actually leads to self-sabotage. For example, if they're really in a loving relationship, they might perceive everything as they are being abandoned, so they might just reject that relationship right away at the start, like when everything is fine, which causes another distress. Or maybe if, for example, they're like very young and their dad or mother said no to something, and they might have like anger outbursts, very reactive because they feel really rejected and abandoned about that.
Okay. I think with all of these things, especially in the mental health space, is that there's a fine difference between like, where it's almost normal and then where it becomes, more a disorder, where it becomes a lot more and it affects your life. Because I think some of those things that you mentioned, I mean, I suppose most people can, like relate to it, but I think where it starts affecting their lives to a huge extent, then it becomes a problem. Is that fair to say?
Yeah, I think there is like mainly diagnosis criteria. Like you said, it's like if it gets too severe, because all of us really scare from them from abandonment to some extent, or maybe being left alone. But if, for example, there are frantic efforts to avoid real or imagined abandonment, so it's, or if there is like impulsive and reckless behavior, for example, a lot of drinking and substance use. Also, this could happen like very young age, and reckless driving, like binge eating, or maybe even like suicidal in ideation, and chronic feeling of emptiness and like very intense anger. Then it becomes problematic. Like if somebody has actually 5 of these criteria by DSM-5, there are 9 criteria, but if they have like 5 of them, then that gets really problematic and diagnostic. But in the UK, in our doctorate program, they told us that until they're 18, we don't tend to diagnose it here, because it's like actually kind of laboring from a counseling psychologist perspective. So we tend to do the best till not like we kind of avoid diagnosing like clinical psychologists do. But in other parts of the world, like actually, for example, US, according to DSM, it's acceptable to diagnose emerging BPD, like borderline personality disorder, even they're under 18. It could be diagnosable, but I think it's a bit more discouraged from a counseling psychology point of view and based on the UK system. And because also it gets better with age, that the research shows. That could be also really helpful, but also therapy could be really needed because there are some severe cases. So this could get really problematic for some people. And then therapy is also needed at that point.
Thanks so much for saying that. I think that gives us really good context, especially from a UK perspective. And I think, is there any merit or is there any advantage to having that diagnosis? And I think what I'm asking from that is, if you get the diagnosis, just say as a teenager, right? Does that help you to get a lot more healthcare? So like, is it easier then to get care from other practitioners? Or is it just that that's why the diagnosis makes sense?
I think some of the people usually in all of those mental health difficulties, they get to be like, there is like a secondary gain, which our supervisors kind of warned us about, because sometimes actually the clients are in the therapy because they like they want attachment, they want to have an attachment and they cannot find it in their caregivers, or they actually want to, some of them even unconditional, like without realizing it, they kind of want secondary gain. So it's really important to be mindful of that. I think because it's a very troubling situation, usually there is like I don't think there is one which is like a secondary game for under 18s because they're not eligible. But if somebody is like older than 18 and has very severe difficulties, there are some secondary gains, as in like maybe they could provide a householding because some of them cannot keep jobs, or might get pensions, or like more like profits from government, or they might feel even the attachment, like the attachment they create with their I think counselors, that gives them attachment. And then that's when it gets problematic, because people usually with who suffer from BPD, they don't want to work through the goals. They just usually want to be attached and they don't want to leave the therapy. So then it could get traumatic when they want to they need to actually leave the service once they start to get better, because they feel abandoned. So a couple of books actually has some client cases and stating that it's really hard to end therapy sessions with people with BPD, because almost all of the endings are quite hard, but even with BPD it's harder, because clients don't want to leave that attachment that's really secure, and also in a way it's healthy for them, but also it doesn't help them in the long run. It's very complicated at, I think, emotional unstable disorders to work through a goal. So they created some actually like dialectical behavior therapy and more like schema therapy for those client groups, which is really helpful because for example with DBT, dialectical behavior therapy, it's like a group setting, and so the individuals learn skills in a group, and they learn how to manage their emotions and tolerating the stress, and also they learn how to improve their relationships. So it's more like interpersonal. And then they might feel less abandoned when it ends, because they get taught that skills they develop a friendship, like they connections in the group, which is a bit more different than just the therapist having just one person in the room. And it's really helpful because it has like mindfulness in it and other skill practices.
Yeah, which is really cool. I mean, it's like proper coping skills, coping mechanisms. So they're learning something that's tangible, that they can take through life, which is quite nice. Do you find the opposite though, Rosie? Do you find, I mean, you spoke about like attachment, like when they have to leave. Do you find like with like patients being able to attach initially, is there a lot more trust involved, or is there anything around the first, like when they first start therapy, is it a lot more difficult to gain their trust?
Yeah, actually, we I read a lot of papers about this, and it's really interesting because lots of research says it's actually the therapy is actually about therapeutic relationship and therapeutic trust. So without establishing that, and it's almost impossible to keep up with the client in good terms, and like getting the client to kind of improve, change, maybe like making life better for them. It's impossible if there is no trust. So we were it's like almost all of the research shows that it's really important to get that trust and get that relationship going, but also depending on the client's needs, like there are almost like 5 different therapeutic relationships. So if, for example, if someone has BPD, usually it's more like, or if they lack attachment or attention in their childhood, it's more like the parental figure. So they tend to see they want to kind of connect to the client in more like a parental level. Whereas with some other client group, it's different. But it's like in the first 2 sessions, it's really important, also from a counseling psychologist perspective, to show empathy and listening to them, like showing unconditional positive regard and like congruence. So these are like the Rogerian principles. So we actually tend to, I think, with counseling psychology, really empathize with client, and we kind of believe that the therapeutic relationship makes the work, like once it's established, actually that's what kind of makes everything better for the client and reinforces them to change by themselves rather than like giving direct diagnosis or advice. I think it's really important. But yeah, I think it's harder to connect at the start, even like this client group, they find it even harder. But I think the parental style, like a therapeutic relationship and being honest and empathic to the client with Roger principles, I think it could be achieved. But also it's really important to keep in mind the cultural aspects. For example, some clients could be from other part of the country, or from like maybe refugee groups. So it's also really important to see how it could affect the therapeutic relationship, and maybe getting a sense of the client's background before, if she or he was referred from another service, or their cultural aspect, and reading about it and making sure it's ethical, like everything is ethical while working with them.
Okay, thanks. Yeah, I mean, I think that sounds good. I think for many of those patients, I mean, I could be guessing, but it's also like an example of maybe a stable, mature relationship, that between therapist and patient. So it's obviously, they probably, yeah, they obviously learned something from that from a skills point of view. Does that make sense as well? Hey everyone, thanks for listening. As always, stay tuned and we'll speak to you in the next episode.